Good afternoon, everybody, and welcome back from the short break. We're going to continue with this virtual conference by the Academy for Professionalism in Healthcare. And we're going to move now to our second keynote address, Racism and Inequity in Healthcare in the Time of COVID-19 and Black Lives Matter. This presentation will be delivered by Dr. Rita Guevara and Dr. Daniel Taylor. Dr. Guavara is an attending physician, newly appointed Assistant Dean of Diversity, Equity, and Inclusion at Drexel University College of Medicine, and Director of Health Equity at St. Christopher's Hospital for Children. She's also an Assistant Professor of Pediatrics at Drexel University College of Medicine. She completed her medical degree at Drexel via their Drexel Pathway to Medical School program for students underrepresented in medicine. She then completed her pediatric residency training and chief residency year at St. Chris, where she has stayed on as a general pediatrician in the outpatient clinic. She is a certified proficient bilingual provider for Spanish and works to ensure quality care for culturally and linguistically diverse families, as well as provide education on language access and culturally effective care for trainees and faculty. Dr. Daniel Taylor is Associate Professor of Pediatrics at Drexel University College of Medicine and Medical Director at Center for the Urban Child. They're talking again today about racism and inequity in healthcare in the time of COVID-19 and Black Lives Matter. Welcome.
Thank you so much, Brian, for that introduction. And I really would like, Rita and I would like to thank you all for inviting us here. Just quick background. Actually, I'll go into it with one of my slides. I know we made Barbara nervous that we had 75 slides, but we'll go through them very quickly and then be able to save a little time for questions and comments. This topic is something that's extremely topical for us all. There's already been some incredible insights, research, conversations earlier today that were touched on this, including the first keynote address, and we really appreciate everything that's been said. And again, are really honored to be here with you guys today. Okay. All right, this is a quick roadmap where I'm not going to read this, but this is what we're going to go over today. I love this quote from D.H. Lawrence: "The eyes cannot see what the mind does not know." What that conveys to me is if we don't know that something's going on, if we don't know about systemic racism, if we don't know about gender racism, we don't know about many other things that affect the families that we adore and care for, we don't really see it. And if we don't see it, then we won't be able to know what we can do about that. So our job today is to really try to inform the participants here of what's going on. Many of you know a lot of this already, so this might be somewhat of a review in terms of COVID-19 as well as Black Lives Matter. Rita and I work in a large outpatient center in the middle of North Philadelphia, which is a beautiful community for us. But like many communities around the country, has a lot of significant challenges. We are in a part of North Philadelphia called Hunting Park. That's the zip code. I'm just going to give you just a quick scenario of just one of the families that I take care of. A single mom, she has a couple kids, maternal grandmother, takes care of them. While mom's at work, she works at an extended care facility. She has to take a couple buses there, has to wait for those buses, has to walk a couple blocks for each one of those buses. And it can take her up to an hour and a half, 2 hours to just get one way to there. And then this graph right here is a synopsis of the health of Hunting Park. So out of 45 communities in Philadelphia, Hunting Park is ranked as the 45th most unhealthy in terms of life expectancy, physical health, low birth weight, and others. To come back to this, Dr. Guavara is going to come back to the Institute of Medicine document and research that came out in 2003. I'm going to just briefly mention this again in the later aspect of the talk on July 13th, 2013, when Black Lives Matter movement was started. It blows our mind that the first coronavirus case in Philadelphia was on March 10th, 2020, which is just less than 7 months ago. Just really, our entire world has changed, our entire city has changed, the way we practice medicine has changed, and actually the way we actually see through different lenses has changed as well. And then I'll briefly touch on what happened on Memorial Day, May 25th, 2020. We all know that, 8 minutes and 46 seconds. So we'll go over that in a second. This came out just last month. The Urban League of America put out a large document called The State of Black America Unmasked. And in it, I'll mention later on some of the research that came out of that. But what the intro of this report said is this really is a pandemic, which is COVID-19 within a pandemic that's been there for over 401 years, which is systemic racism in this country. So our goals are really to kind of hopefully change some hearts, change some minds, and ultimately the only true way to change everything besides the first two is to really change the systems that have done this to Black and Brown and Indigenous people for centuries. One thing we always try to do here in our practice, and I'm sure many of you do as well, is to really take a trauma-informed racial equity lens in every decision we make. When we walk into the door of a patient's room, we walk into a meeting with administrators, when we work with different community-based organizations, and even when we're developing handouts for patients, really coming up with everything we do is a trauma-informed racial equity lens. It's extremely, extremely important. Quickly, the pandemic, all of us unfortunately are just so versed at this. Some of the new verbiage you can see here, I won't go over it. Never heard of Dr. Fauci before this. The term rationing came up for the first time. I thought this was something we would never have to do. They had to do it in Italy and a little bit in New York. Or not, I had to go back to medical school notes to kind of remember what that meant. But this pandemic has really decimated the world. And unfortunately, as we go further, it has decimated one segment of the population much, much more than others. This is a picture of our hospital. It hit, we, as many of other physicians on this call did, we had COVID command centers. We did what we could to protect our employees, to protect ourselves, to protect our families. One thing we have yet to do is really to do community-wide testing here. I'm sure some of your institutions have done that. We're working on that, but that is something our community needed, and we just weren't prepared to set that up as quickly as it needed, and we still don't have that. Really screening for basic needs, and we'll go over that in a second. But for now, Dr. Guavara is going to take over. I'm going to scoot away, and she's going to go over the historical causes of racial inequities in medicine.
Good afternoon, everyone. So I want everyone to take a minute to just think about the pre-existing condition that exists in our country. And this quote from Reverend Al Sharpton is quite powerful in describing the over 400 years of systemic racism, and now is the time to really get the knee of racism off of our necks. So there have been many historical crises throughout our country's history. The financial crisis in 2008 is a great example of how crisis can really help further show and magnify the inequities that exist in our society. Just thinking about the wealth inequality and how income is distorted in our society. The left graph just shows the changes in income over the last few decades from 1990. You see a dip around what would be 2008, but there are certain subsets of the population, the top 0.01%, that haven't really seen that issue. Looking to comparing household wealth for Black and white Americans, you can see that the wealth for white households in the navy colors continuing to increase since 1989, with an unfortunate stagnance in household wealth for Black Americans. And just as a reminder, the richest 3 Americans have more wealth than 160 million of us. And then moving on to discuss racism and inequality specifically in medicine and in pediatrics. The Institute of Medicine in 2003 released a very important report called Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare. The main take-home point of this report was that even when they accounted for differences in access to care and socioeconomic conditions, even when controlling for all of that, they still saw that race and ethnicity remain significant predictors of the quality of healthcare that people received. And fast forward to last year in August of 2019, the American Academy of Pediatrics released their first formal policy statement on the effects of racism on child and adolescent health. And so just to make sure we're all on the same page, racism here talks about a system of structuring opportunity and assigning value based off of how you look, how you identify, in this example, race, and it unfairly disadvantages some people while unfairly advantaging others. And as Dr. Thompson mentioned earlier, you end up having an entire society that is negatively affected by racism. So we think of racism as a socially transmittable disease, so a different type of STD. It's something that's taught, it's passed down, it's contagious. And in reality, we know as scientists and clinicians that race is a social construct. And so it's important for us to start thinking about how we can change the culture of medicine, of science to reflect that. Thinking about health equity versus equality. So quick recap, equality is giving everyone the same thing, whereas equality looks at what people need and addresses those needs to have the effect of everyone being healthy. And so when we use a different type of analogy, the reality is there are vast gaps in healthcare quality and care based off of certain patient populations. Equality is, let's just give everybody what they need, or let's give everybody the same thing. Equity is, let's give people what they need to have a desired outcome. In this example, being able to watch the baseball game. But the true goal is liberation, removing those barriers completely, addressing those systemic issues and inequalities that lead to us having to kind of compensate accordingly. So the 2020 Equality Index is essentially a calculation of the social and economic status of races compared to whites. And the Black Equality Index here, by comparison, was 73%, and the Latinx, which is the gender neutral term for Latino, Equality Index was 78%, almost 79%. And this is eerily familiar to the Three-Fifths Compromise of 1787, which counted enslaved people as 3/5 of free people. And then thinking about how it plays into healthcare, you have in the chart, the bar chart at the bottom, a large percent of Black Americans lack health insurance compared to whites. And then when you look at the net worth of different households, again, you see that same disparity. In pediatrics, we have failed. We have not systematically addressed racism's impact on health of children and their families, and we have not adequately prepared pediatricians to be able to identify and manage those effects. And as a community, a medical community and society, we've also failed because even though we're starting to, identify that there are disparities, a lot of the focus has been on reinforcing stereotypes or blaming individuals who are being affected by these inequities instead of thinking about the systematic issues that lead to those. So I wanted to take a quick pause and give people an opportunity to think about historic examples of racism in medicine. And if you feel moved to do so, you may type them into the chat, and I'll take a few moments for people to reflect, and then we'll continue on with the talk. All right, so in thinking about examples, unfortunately, there are several examples that would make up their own talk, but I'll highlight a few here. Back when slavery was a part of society, there was a white physician by the name of Thomas Hamilton who would leave enslaved African Americans in burning hot pits to look for a cure for sunstroke. Fast forwarding to the 20th century, the federal governmentally funded and overseen Tuskegee study was something that I think a lot of people are familiar with, which prevented Black men from receiving treatment of syphilis in order to study the late term effects, even after penicillin was developed, and moving to the effects of systemic racism in medicine and research for women. When the oral contraceptive was being developed and researched and studied, they actually went to Puerto Rico and utilized established family planning clinics to test out the oral contraceptives, which at that time had a much higher dose than what's used now. And these women were not told what they were being given. They weren't told that they were part of a study. Another famous example is Mrs. Henrietta Lacks, whose cervical cancer cells were utilized to harvest immortal cell lines and used in research for decades after, without her knowledge, without the consent of her family, and without really getting that recognition of her efforts until recent, or of her influence in medicine until recently. Other examples, Holmesburg prison experiments. This was a prison here in Philadelphia, and the inmates were used for dermatology experiments. Mississippi appendectomies talks about the forced and unknown sterilization of multiple women in the South, many of whom were minorities, and so much more, including most recently the reports that are coming out of immigration detention centers of women being sterilized without their knowledge or consent. Other examples in medicine, adjusting GFR for race. If you are African American, controlling for all other factors, you are 3 times more likely to have an amputation compared to a patient who is white. How we report suspected child abuse is influenced by race. There are biases in how we assess for pain and how we treat, as the study from the University of Virginia recently showed, and thinking about algorithms that we utilize in clinical medicine. Black and Latinx patients with the same symptoms are still being referred for specialized care much less often than their white counterparts. And that was a recent piece out of the New England Journal of Medicine. And in thinking about pregnant people, if you are Black, you are much more likely to have complications during your pregnancy, higher rates of low birth weight in your babies. And a famous example is Serena Williams, who had a history of pulmonary embolism, has a lot of resources at her disposal, had to really advocate after she had her daughter Olympia to get evaluated for a PE postpartum, and initially was not being paid attention to by the rest of the team until finally she was able to convince them to test her and then subsequently manage her for that. And most recently, there was a study that came out talking about the physician-patient racial concordance and how they're seeing disparities in birthing mortality for newborns, specifically comparing white and Black newborn babies. And then COVID. Studies out of the University of Pennsylvania are showing that Black and Hispanic women are more likely exposed to coronavirus, and we'll go over some of the other reasons why that may be. And so what we want to further highlight through the next few slides is how structural this is. We talked a little bit about historical racism. If you think about redlining, gerrymandering, fair housing, other institutional structures that are in place, you'll see inequities in all of those. Moving on to highlight environmental racism. So there are different size particles in the air, the smallest of which are called PM 2.5. So it's less than 2.5 microns in size. For every 1% increase in those very tiny particles, you have an 8% increase in COVID death per the studies that have come out. And so they're seeing disparities in the distribution of this particulate matter and where it's coming from based off of race and poverty status. So Black people specifically are exposed to 54% more of these particles than the average person. Another concept is the heat island effect. Here in the zip code around our hospital, it's the worst in terms of there being too few trees, more blacktops, which leads to 20 degrees hotter temperatures on some summer days compared to other places around the city. And all of that can contribute to health. As a profession, there was the Heckler Report in 1985 that recognized that there were disparities, but unfortunately, they didn't propose government funding or how to address it, and actually blamed individual Americans that they need to take control over their health and completely ignored the structural factors at play. Dr. Johnson spoke about implicit bias, so this is another reminder about how that plays into patient care. Pediatrics a couple of years ago came out with this systematic review of implicit racial bias in healthcare. And so we know that there is a lot of implicit bias, how to address it, mixed results. And we know that when you have more implicit bias, you have poorer health outcomes for your patients. So definitely an important thing to keep in mind. I'm going to transition over to Dr. Taylor to talk about the next part of our talk.
All right, glad we're on chairs with wheels to go back and forth here. I'm going to put on my doctor hat, scientific hat, and just really quickly go over the physiologic effects of racism. Again, racism against Black people in America, you can imagine what this would be doing if you were African American or a person of color, to your heart rate, to your hypothalamic pituitary adrenal axis, some of these statistics, who controls all the wealth. African Americans are 2 times more likely to be unemployed, even worse right now with the COVID pandemic. Black students are 3 times more likely to be suspended for the same infraction, contributing to the school to prison pipeline that we see all too often. African Americans make up 13% of the general population, but 40% of the prison population. And Blacks are shown still, even to this day, 50 years after the civil rights movement, still shown 18% fewer homes and 4% fewer rental units than white people, with the same exact demographic, same exact income, same exact applications to those different homes. And unfortunately, Black drivers are 30% more likely to be pulled over. And as we've seen, for decades, but even more so recently, thank goodness, pulled over and potentially killed. And one study showed that 67% of doctors do have a bias against African Americans. An implicit bias, sometimes it's more explicit, and hearing some of our colleagues used words that are very hurtful, but more likely it's implicit. But 67%, 2/3 of us have bias against African American patients. So what are some of the major physiological and psychological effects? It's really about the hypothalamic pituitary adrenal axis. If you have a constant fear or trauma or anger going on and you anticipate future events before they happen, that can have wear and tear on your body. We'll talk about that. There's 2 areas I just want to focus on in the brain. The hypothalamus, which is very, very susceptible to cortisol, especially, which is secreted by the adrenal gland when there's a stressor. such as systemic racism, such as fear of COVID, such as seeing your cousins, your neighbors being affected by this horrific pandemic, and again, the racism pandemic within a pandemic. The unfortunate thing about the hypothalamus, especially if we're talking about pediatrics, young children, is that's the area that's responsible for learning. So when there is a stressor like systemic racism or fear, that can affect kids' learning when they start school. And then the amygdala, which is the almond-shaped area of the brain that's really responsible for empathy and risk-taking and communicates beautifully with the prefrontal cortex, that also is affected potentially by unbuffered stressors such as racism, thus making people sometimes more likely to take risks, potentially having a little bit less empathy, and then also add to that many other factors, potentially having some segments of the population being a little bit more at risk for getting involved in the juvenile justice system and other effects. Weathering is a term that we use often in terms of what this constant drizzle, sometimes flood on certain days of racism can do to individuals who are dealing with that on a daily basis, this kind of perceived stress. And Dr. Geronimus talks about weathering kind of like I, as a white male, have an umbrella of my white privilege over my head. So if it does rain, it really doesn't get me too wet. I'm not feeling worn down. I'm not feeling wet. Whereas other populations, especially populations of color, don't have that luxury of having that umbrella. And over time, it can really cause some extreme systemic effects in your health, both behavioral as well as physical health. And it's really weathering. She postulates that this population of health inequity reflects structurally rooted biopsychosocial processes stemming from political, cultural, and economic oppression of marginalized groups. That's what we're talking about today. So really quickly, we're going to go over the COVID-19 inequities. Many of you know this. These were some of the issues we see in Philadelphia, around the nation, before COVID. We call them social influences of health. But there are also social determinants of death, kind of on the same side. Poverty, there's large amounts of poverty, and unfortunately children in America, those under 18, have the highest risk of being impoverished. And if you're impoverished, then you have more stress, which can affect your hypothalamic pituitary adrenal axis and everything else going on in your body. Food insecurity, we'll come back to all these, and then underemployment, evictions, we'll talk about that. These health inequities we see over and over again. Transportation issues, mass incarceration we touched on, single parent households, and on and on. But then COVID hits, March 10th again, 2020, this year. That's when it occurred. People got their stimulus check. Some people, not everybody, some people had to go through a lot of hoops to get that stimulus check. But now food insecurity is 3 times more than it was in the 2008 recession. Underemployment, this goes up and down, is close to 30 million. Evictions, there's a moratorium that the CDC just extended to December 31st of this year. But in Philadelphia now, typical evictions in Philadelphia are about 15,000 a year. They're talking about potentially there being 100,000 evictions December 31st, if things aren't done about that. We're worried about child abuse, and actually we're talking to our hospitalist colleagues. They are seeing, unfortunately, more severe cases of child abuse. Reports of child abuse around the country are much lower because mandated reporters like Dr. Guavara, myself, teachers, daycare workers, those kids aren't in our clinics as much. They're not in school. They're not in daycare as much. So it's being reported as well. Outbreaks around the country in prisons, especially those who are older, just like in nursing homes. And we'll get back to the educational inequities as well. And this is just a quick graph showing that mothers with children under 12 who are the most susceptible to unbuffered stressors have the highest rates of food insecurity in America. So let's go back to our family that I was talking about. This is just to recap exactly what she has to do to get to work and what puts this family in a higher risk factors for COVID. It's a multi-generational household, like many of the households we take care of, in a hyper-segregated neighborhood. That's a whole topic within itself, why certain neighborhoods are hyper-segregated. So there's similar scenarios. So it's not uncommon that your next door neighbor, your neighbor next to that person have the same exact issues they're facing, so that the susceptibility to COVID is higher. Systemic racism we'll talk about. This commuting that this mother had to do, being on a couple different buses, having to walk, having to wait for a bus, that predisposes her to potentially getting COVID, working in a nursing home, which was the only job she could find. In these hyper-segregated neighborhoods, there's not as much resources for employment, unfortunately for education. So a lot of our families have to work outside of their neighborhood. So really structurally susceptible to COVID-19. This is a graph just showing kind of structural susceptibility, not just to COVID-19, but to poor health in general. This is where we are, smack dab in the center of the susceptibility. And then this is a graph of segregation, high segments of multi-generational segregation. Again, kind of we're in the epicenter of that. Essential workers, that's a new term since COVID, and these are just some of the horrific but important headlines that came out from research, from reporting about essential workers, that they've always been essential, but they've just been invisible. This one quote from the New York Times: "Those still working generally cannot do so from the safety of their living room couch. They risk death to obtain the necessities of life." Social distancing, and I have a graph on that, is a privilege. Women and minorities shoulder frontline work during the pandemic. That's definitely what we're seeing here in Philadelphia. I'm sure you're seeing that as well where you are. Again, we are not essential, we are sacrificial. This picture gets Dr. Guavara and my hair standing on end, how horrific that this woman would have to give a manicure to this other woman with all this gear on just to pay her bills. We'll go over the next. We're trying to keep it apolitical here, but we'll kind of skip by that headline. You can read it yourself. So who can work from home? This is a recent statistic showing that almost 30% of white Americans can work from home versus 20% of Black and 16% of Latinx. Testing, we talked about how we still at this large hospital that we work in don't have community-wide testing in this part of Philadelphia. It's very, very difficult to get testing in this part of Philadelphia, and statistics show in Philadelphia, and I'm sure it's the same in many of your communities, that the highest risks of COVID deaths, those zip codes, have the lowest rates of availability of testing. Just another inequity that the COVID pandemic is demonstrating. This is one of our heroes, Dr. Ala Samford, here in Philadelphia, walking with our health commissioner, Commissioner Farley. She saw this, she did something about it. She invested in a mobile testing unit. Other African-American physicians and others kind of worked with her to go to mosques, to go to neighborhoods, to go to community organizations to get people tested that should be tested. And of course, this picture up here is at the beginning of the COVID epidemic, just the celebrities, how they can easily get tested, and many of the people we care for could not. For many Latinos in Philadelphia, getting sick it's just really, it's an impossible task. They can't get sick. They're taking care of 3 of their children. They're commuting. They're teaching their kids at home. They're bringing their Chromebooks to visits with us and trying to get their schoolwork done. It's a very difficult task. Going back to the state of Black America, unmasked, the pandemic within the pandemic, you can see infection rates for Latinx are much, much higher per 10,000 population nationwide. Blacks 62 per 10,000, and whites 23 per 10,000. And death rates kind of mimic that statistic as well. So you can see what horrific inequities there are in the death rates for those persons of color. This CDC report came out just not too long ago about children. We take care of children. Thank goodness they haven't been affected as much. Nobody should be affected by this, especially with the inequities that we're seeing. But out of 121 pediatric deaths reported to date to September 15th, 75% of those children were children of color. So it's not just adults who are Black and brown and indigenous. It is the children that we take care of. We're not doing enough to prevent this. So our Surgeon General, Jerome Adams, and excuse me if I'm not even too sure if he still is the Surgeon General. I think he is, but things change so much. Just like the Heckler report that Dr. Guavara discussed before, he, in an address to different journalists and to the nation, he talked about that we, meaning he's an African-American, we need to avoid alcohol. We need to avoid tobacco and drugs. Do this for yourself, for your abuela, do it for your granddaddy, do it for your big mama. He was trying to connect with these populations, do it for your pop-pop. Dr. David Williams of Harvard retorted the higher death rates against African-Americans are not linked to individual decisions these communities have made, but we're looking at societal policies driven by institutional racism that are reproducing the results that they were intended to produce. If you want to see an amazing 12-minute TED Talk, just Google Dr. David Williams. We had verbiage when COVID-19 came out. We have some new verbiage. Critical race theory is not new, but there's a lot more focus on this kind of explicit acknowledgement that the workings of race and racism in social context is really driving this disparities in COVID, driving this disparities in imprisonment, driving this disparities in so many of the things we're talking about. Anti-racism, not racist, is the new verbiage we should use. It's more proactive, and Dr. Guavara is going to talk about that. We use, and a couple other presenters use microaggression. We still use that as well, but think about it as racial abuse instead of just microaggressions. We're going to go over the COVID learning slide. We talked about essential workers, and my children are now considered the Trayvon generation. Again, racism is and has always been a public health crisis that really is affecting the people we care for so much. And really, again, every decision we make needs to be seen through a racial and equity lens. Really, the coronavirus pandemic has really stripped bare the racial divide in the health of our nation. And Representative John Lewis, right before his death, commenting on the Black Lives Matter movement, said this: the thing she said is racism is now out of the box, and there's no going back. There's no going back. So it is out of the box. This is why we're doing this talk. Hopefully, it continues to be talked about. Hopefully, systems change to just help change this inequity that we're talking about. Really quickly, I'm going to go to the Black Lives Matter movement and George Floyd. This was started July 13th, 2013. It's a decentralized movement in the United States, advancing nonviolent civil disobedience. It started after Trayvon Martin was murdered by Mr. Zimmerman. It's tough for me to say even Mr. And when he got let off after this murder, that's when it started. And then on Memorial Day 2020, we all know what happened to George Floyd. There's white coats for Black Lives. This picture right here is what happened in our city on our expressway, where there was peaceful protests and police corralled some of the protesters and started shooting tear gas at them as they were trying to escape over a fence away from the fear and the rubber bullets that were being shot at them. And then you can see also this graph in the center. I know this is a busy slide, but you can see how persons of color are fearful of the police and very justified in many cases. African Americans, when they see a police officer, only 30-something% feel more secure, majority feel less secure. Dr. Guavara is now going to go over anti-racism, and then I'll come back to things we can do individually as well as systemically.
So as I'm sure many of you are familiar with the name Ibram Kendi, he's a professor that's really pushing forward this movement of anti-racism. And so when you think about how you as an individual can move towards being an anti-racist, there are different zones. And so reflecting on where you're at currently and then what you can do to move forward is important. Make sure that you're committing to this effort. This statement I think is really powerful. So no matter how open-minded, socially conscious, anti-racist I think I am, I still have old, learned, hidden biases that I need to examine. And it's my responsibility to check myself every single day for my stereotypes, for my prejudices, and ultimately for discrimination. And so strategies that we can do as health professionals, we can advocate for all to address these biases and these inequities, not just in our field, but in the justice and educational systems as well. And then if we are able to reduce and buffer those adverse events that alter the health and self-value of youth, we can further empower our patients and their families. And then acknowledging and addressing implicit bias and making sure that we're striving for a more diverse and culturally effective workforce. And then I'll lead it back to Dr. Taylor.
One thing we developed at St. Chris several years ago was a site called Cap for Kids that lists all the different resources in our community, especially for lower income individuals. We have a whole section, like many of your hospitals and many of your social workers, on COVID-19 resources. I am so proud, and Dr. Guavara is so proud of, not to brag about our residents, but when they come precept with us, they'll come precept us. The first things they say is, this is so-and-so, the parents got their stimulus checked, they registered to vote, they did the census, and if they have, if they answer negative to any of those, they know exactly how to help those families with those three extremely important ways to address some of the systemic issues that we're talking about today. And then for the issues that affect families in the day, like not having enough food, potential for eviction, there are resources on the it's capforkids.org website, and it's been replicated in 14 communities nationally. But we use this on a daily basis just to help that individual that we're seeing right in front of us. Dr. Guavara put together an incredible resource list of anti-racism resources. There's a tiny URL there that I'm sure can be shared with everybody here as well. There's something called the COVID Project that looks at racial disparities in children in terms of COVID, and a lot of other incredible data is listed there as well. So this is what I've been terrified since the beginning of this pandemic, pandemic within a pandemic, the child poverty rate going up and up and up, underemployment continuing, this eviction moratorium ending, of potentially 100,000 individuals getting eviction notices, their locks being changed, their couches being put on the sidewalk. Typically, the most at-risk individuals for that are single mothers of color on the street trying to find a different place to live, bunking up with others while there's still a pandemic. Inequities we've talked about, the moratoriums on utilities are still there, but they will stop and the bills will keep continuing. And then if the pandemic continues, when that moratorium's over, many utilities will be shut off. We're hearing a lot from our domestic violence colleagues that there are shorter calls to the domestic violence hotlines because more people are kind of having to live together, or somebody's not going to work who is the abuser. They're just quick calls like, I'm calling because I'm scared, I gotta go, and they hang up. Food insecurity, like we talked about, is worsening. Teen pregnancy, we're not too sure if that's gonna go up or down. There's educational inequities. We're gonna talk about that in just one other slide. I know we're running out of time and we wanna give you lots of time to ask any questions or give us comments. What are we going to do with all of those who have lost? We lost 200,000 individuals already in America. Many of the people that we take care of here know somebody who has been extremely ill or have died. What are we going to do with all that loss when your mother, when your grandmother who was so involved in your care is not there anymore? There's something called the learning slide that many of us know about during the summer months, but now add to that the COVID-19 slide. So those individuals who are in more distressed neighborhoods where there's not investment in public education are going to be way, way, way behind those who are more privileged in different communities. And a study came out that shows that Black students in Pennsylvania are 2 to 3 times less likely to have in-person classes, and we see that everywhere. This came out just 2 weeks ago from NPR and Harvard Chan and Robert Wood Johnson, showing that a majority of households are reporting serious financial problems, 63%, and you can see the disparities by race and ethnicity and income. And then, so many parents are struggling. 3 in 5 households in New York City with children reporting serious caregiving problems, finding physical play spaces, keeping children's education going, helping to adjust to major life changes. So this is really hitting our families hard. And then just going back to one of the original slides, just getting us all to think about every decision that we make and every conversation we have through a trauma-informed racial equity lens. That's really one of the true ways of healing and moving forward and helping those that we care so deeply about. This is the last slide. The United States has a chance to emerge from this latest crisis as a stronger nation, more just, more free, more resilient. Like Rep. John Lewis said, it's now out of the box. We need to seize this opportunity now. This is a quote that many pediatricians use. The test of the morality of a society is what it does for its children. So just looking at that child's beautiful face, we need to, as a society, tell him, tell her that they are important, that their lives are important, that their parents are important, that their health is important, that they are the future of this country. But we don't have time to wait. We have to do it now. So we can take any questions or comments that you have right now. I'll put on my mask.
Thank you, Rita and Daniel, for a sweeping overview of substantive reasons to pay attention and change things. Comments, questions through the chat box? As another pediatrician, I just have to ask you, how well do you think people are attending to this at a national level in the pediatric community? I know you gave a lot of attention there to the Philadelphia community.
Yes, so the question was, how responsive has the pediatric community been to the racial justice movement? I think we as pediatricians have done a fairly good job of recognizing that these issues have been around for a very long time. And so I think a lot of my colleagues are viewing this as an opportunity to augment what we've all been doing in our respective practices and our respective institutions, and really take it to that next level and to transition from caring for the individual patient and family to really looking at what is our structural competency as providers? How can we look to those structural changes? So I think we're all just trying our best, and it's a balance between individual needs, organizational needs, administrative needs, and societal changes.
And I certainly appreciate that. Dr. Reynolds asks, this can feel so overwhelming. Where might we begin, whether we're in pediatrics or adult medicine?
That's a great question. So it is very overwhelming, and I think it's a mix of looking inward and identifying areas of growth in our own knowledge base, as well as looking to our respective medical societies and organizations. The American Medical Association, the AAMC, the National Medical Association, which is the organization, historical organization for Black and African American physicians. They all have put out statements, action items, and it goes beyond our work in medicine and really our work as citizens. As Dr. Taylor mentioned, voting registration, informing patients and families about what resources are available to them, I think is really important.
Yeah, thank you. And thank you, Patrick Heron, for putting up a nice link, URL in the chat box to a tiny URL that lists a lot of resources and organizations that people can get in touch with so that they don't feel so overwhelmed. I think from the standpoint of time, we need to wrap things up. And once again, I appreciate your presentation and everybody's attention throughout the day.
Thank you very much for inviting us, and we really have enjoyed the day.